hematology, oncology, platelet disorders. So for the platelet disorders, what we have to be looking at, instead of PT and PTT, because there's no coagulation factors affected, we have to look at our bleeding time and our platelet counts. Now, normally we're going to have normal platelet counts due to the fact that there's no destruction of platelets, as well as no overusage of platelets. However, there are some that do affect platelet count, and it will be a dead giveaway for it. So starting off with Bernard-Soulier syndrome, we're going to see as an autosomal recessive defect. And the reason that this occurs is the fact that we have a decrease in GP1B receptors. And what we already learned today is the fact that GP1B is the receptor located on platelets that bind to von Willebrand factor. So without GP1B, we have an inability for platelets to bind to von Willebrand factor in order to start that fibrin clot, okay? So we get a decrease in platelet aggregation, and on peripheral blood smear, you're going to see very large, big, abnormal platelets, okay? We're going to have an increase in bleeding time because, once again, if we have abnormal ability for platelet aggregation due to the fact that we lost GP1B, then that means we're going to take longer to bleed, so increased bleeding time. However, platelet count usually is normal. It could be decreased at times, but they don't normally ask that. Now, what they like to ask is the ristocetin test. Now, what ristocetin is that it just brings together von Willebrand factor with platelets, okay? However, if there's no receptor present, then we cannot correct Bernard-Soulier patients, okay? So what happens is, if I were to take a serum from a patient that does not have this pathology and give them ristocetin, their blood will agglutinate. And the reason behind that is because ristocetin binds von Willebrand factor to platelets. However, patients with Bernard-Soulier, if I were to give them ristocetin and take their serum and put ristocetin in the blood, I would not see any agglutination because they lack the receptor that helps bind the platelets to the von Willebrand factor known as GP1B. So we cannot correct this by giving this pathological patient normal serum because we cannot provide the receptor to this patient. However, we can see that we can correct ristocetin test via von Willebrand disease, and we'll talk about that later. Next is Glanzmann thrombocythemia. This patient is going to have autosomal recessive defect in aggregation, but it's due to the fact that they have a decrease in GP2B3A. That's all you really need to know. The blood smear shows no platelet clumping, and we're going to have an increase in bleeding time. Next is immune thrombocytopenia. As I said prior, that usually our platelet count is normal. However, in this case, since we have autoimmune attacking our thrombocytes, our platelets, we're going to have a decrease in platelet count. So this is the only one that has a decrease in platelet count, and you're going to have an increase in bleeding time due to the fact that we have destruction of our platelets. Now, one common cause of this is anti-GP2B3A antibodies, okay, which leads to splenic macrophages causing phagocytosis of the platelets, but it can also be secondary due to a previous viral infection or sickness. The main presentation that I would be careful of, that you have to know, very high yield, is that a patient comes in, they've had a previous viral infection about a week or 2 weeks ago, and then now they present with decreased platelet count and an increased bleeding time. Okay, so be aware that that is going to be the presentation for patients with immune thrombocytopenia, okay? The labs will show for this patient for immune thrombocytopenia increased megakaryocytes on bone marrow biopsy. We know that megakaryocytes produce our platelets. So in response to the decrease in platelet count, our precursors are going to increase, okay? And so that's a question that they love to ask as well. Lastly, it's uremic platelet dysfunction. So at any time, if we see a patient that presents with end-stage renal disease and they're constantly bleeding and they have an increased bleeding time, all labs normal except for that bleeding time, you know that there is uremic platelet dysfunction. Put the answer automatically. Any patient that has end-stage renal disease, that has all labs are normal except for bleeding time, put uremic platelet dysfunction. For our purposes here for step one, that's the only thing that we really need to care about for anything that has renal dysfunction as well as platelet dysfunction. And the fact behind it is that you have uremic toxins that accumulate, which lead to an interference with the platelet adhesions.